Hello, this is Dr. Arenze Ikeme. I am a nephrologist and also a hospitalist, and I do take care of patients in the hospital. I'm also board certified in nephrology and an associate professor, Campbell University in North Carolina. I teach medical students, and I want to use this opportunity to talk a bit about prognosis after cardiac arrest, especially since we encounter this quite frequently in the hospital, in different scenarios, of course. And so this is just a little bit a basic understanding to help medical students as part of their learning during their inpatient rotation, as well as new physicians who might just be graduating from their residency program and they are going to be working independently independently out there in the hospital setting or other providers, physician assistants, nurse providers or nurse practitioners. And so I hope this at least gives you an idea on how this is addressed and how to assess patients' prognosis after having a cardiac arrest. So the lecture outline I'm going to use, first of all, going to talk about the overview of sudden cardiac arrest, factors affecting prognosis post-cardiac arrest, interventions that may improve prognosis post-cardiac arrest, and understanding hypoxic ischemic encephalopathy post-cardiac arrest, because that will definitely help you know where to go from there after the patient survives a cardiac arrest, and also how to discuss with the family on the prognosis and decision going forward. So as far as the overview of sudden cardiac arrest is a sudden loss of all heart activity, leading to loss of pulse, cessation of breathing, loss of consciousness, and sudden collapse in the absence of a non-cardiac condition like an intracranial bleed or airway obstruction. If resuscitation or interventions are not initiated, the condition progresses to sudden cardiac death. And only 1/3 of cases are witnessed, unfortunately. So the types of arrhythmias leading to cardiac arrest could be ventricular fibrillation or tachycardia, Brady arrhythmias, and asystole. And most cases are actually the Brady arrhythmias and the asystole. Possible causes of the sudden cardiac arrest would include cardiac causes like myocardial infarctions in 65 to 70% of cases. Some people who have structural heart disease that are prone to arrhythmias, the cardiomyopathies, account for 10%. Some of them are arrhythmogenic. These are cardiac causes, like QT prolongation, Brugada syndrome, where there is a problem with the sodium ATPase pump in the myocardium, WPW, Wolf Parkinson White syndrome, and etc., other forms of arrhythmias. Some of the non-cardiac causes, of course, which make up about 15 to 25% of cases, would include trauma, severe hypoxia, electrolyte abnormalities. These are the ones we see more in the hospitals. Pulmonary embolism, drowning, severe acidosis, etc. And the major cause of death after cardiac arrest is actually the hypoxic ischemic brain injury from the cardiac arrest. And so this is important to note. Sometimes it's not the primary cause of the cardiac arrest, but the complication, the hypoxic ischemic brain injury that eventually leads to death or disability in most cases. So what are the factors affecting prognosis after cardiac arrest? Okay, let's start with the history as usual. So the demographics, men, unfortunately, are more, the prognosis is worse with men, actually 2 to 3 times more than with females. Age, the elderly, definitely the prognosis is worse with them than the younger patients. Still part of the history, comorbidities, those with underlying cardiac disease, underlying diabetes, especially if not well controlled, those with advanced or end-stage kidney disease. Of course, other metastatic disease or other debilitating diseases. These are comorbidities that already make the prognosis poor for these patients, more so when they have a cardiac arrest. as part of the history, whether the cardiac arrest was witnessed or unwitnessed, that also affects the prognosis, because the availability of a bystander who can, initiate CPR early enough, does improve prognosis. Those with non-shockable rhythms also have poorer prognosis. That means those with the bradyarrhythmias or the asystole, the prognosis is poorer than those who have like ventricular fibrillation or VTAC, which can be shocked. So the rhythm at initiation of CPR can affect the prognosis, as I said. Asystole and PEA has poor prognosis. Prolonged resuscitation, if it's lasting more than 20-25 minutes before return of circulation, that's also poor prognosis, a poor prognostic factor. Those with shorter CPR duration, 5 minutes, maybe 10 minutes, tend to do better than those with longer duration. And, it's unfortunate, survival after out of hospital cardiac arrest to hospital discharge is roughly 10%, which is pretty low. So let's look at other factors that affect prognosis. In your physical examination, the level of consciousness after resuscitation, and of course, best after 72 hours when you've done all you can do to improve the prognosis. Their level of consciousness does affect prognosis. People, neurological findings, people who remain comatose after resuscitation, people with myoclonic jerks who have lost brainstem reflexes like corneal and pupillar reflexes, with no spontaneous breathing, their response, these are prognostic factors that are pretty poor, suggest poor prognosis for these patients. We don't typically use labs to assess prognosis, but there are lab tests that has been tested and has been studied that in cases, maybe in certain cases, might be important. So there is CSF analysis for neuron-specific enolase can often predict prognosis. Again, this is not commonly done, but if there are cases where this is necessary, options like that might actually help. Imaging, CT head, if there is severe hypoxic ischemic injury to the brain, there might be loss of gray-white matter differentiation or intracranial bleeds depending on the primary cause. And these are things that will suggest poor prognosis, of course. It means it's pretty severe. EEG, off sedation, of course. If there is some variability and reactivity to commands, that's actually a good prognostic factor. It means the patient might still be in there. Functional MRI of the brain, which is not readily available, can show evidence of response to commands or prompts also. So what interventions can improve prognosis after cardiac arrest? Early initiation of CPR can't be overemphasized. Being able to start CPR, bystander CPR does make a big difference. Identifying the shockable rhythms early enough so that you can go ahead and defibrillate can definitely help. Hypothermia treatment is one that is indicated if the patient remains comatose after return of circulation, and it involves cooling the temperature to about 33 to 34 degrees. Most times we use external cooling devices rather than infusing cold solutions. We use external cooling devices, and we try to maintain that low temperature for about 24 hours before rewarming the patient. This has been known to improve prognosis, increases blood flow in the brain, and outcomes have been better in patients who got the hypothermia treatment as soon as possible. So if you want to review the prognosis after cardiac arrest, you've done the hypothermia protocol, you've taken care of all the abnormalities, electrolyte issues, you've evaluated the cause of the arrest in the first place, you've handled that. You want to be able to review the prognosis with the family also. So the way I try to look at it is I try to draw this diagram where I look at the brain, the brain stem, and the spinal cord. And I always tell the patients that, if the cerebrum, the brain, is affected, the patient can be in a vegetative state. If the brainstem is affected, then severely they are brain dead. And the spinal cord is usually the last to die, which is a primitive reflex. The cerebrum is where cognition and intelligence, interaction occurs. The brainstem, I call the area for specialized reflexes like your corneal reflex, pupillary reflexes, your breathing pattern, your sleep wake cycle. These are specialized reflexes. And then the spinal cord is for the primitive reflexes. And that's the way I try to explain it, even though it's a little more complex than that. So you should be able to make a distinction between patients in coma after having a cardiac arrest, what it means to be in coma, persistent vegetative state, and what it means to be brain dead, pretty much. And so coma is a state of pathologic unconsciousness. The patient is unaware of the environment, and it can be due to a dysfunction of the reticular activating system, which is in the brainstem above the mid-pons area, or a dysfunction of both cerebral hemisphere. And it's true that, when they're in a coma, you're not sure what the outcome will be. And someone in a coma can progress to recovery. They can also progress to a persistent vegetative state or death. So when they are in a persistent vegetative state, it means they wake up. So there is wakefulness, but there is no awareness. And this is usually caused by bilateral cerebral hemisphere dysfunction. They can have normal sleep cycles. That means they can sleep, wake up, they can yawn, they can breathe over the vent. They are arousable because they have preserved hypothalamic and brainstem function. But they can't interact with the environment. They don't understand what you're saying. They can't hear you or make sense of what they hear. And if it's more than 3 months, then it's permanent most times. Brain death means there is irreversible cessation of not just the cerebral, but the brainstem function. And you're legally dead. These are patients who have no corneal reflexes, no pupillary reflexes. They are not breathing over the vent. And if you need to confirm it, we use an apnea test to confirm. And what we usually do is we either disconnect the patient from the vent or put them on a T-piece, wait for the PCO2 to go up to 60 millimeters mercury, or at least 20 millimeters mercury above their baseline PCO2. And then wait to see if there is a breath in 8 to 10 minutes. And if there is no breath, they are declared brain dead. And so you want to be able to make a distinction where the patient is. After you've done your hypothermia protocols, you've given them 72 hours, and you assess them, you assess their neurological status and see where they fall in this case, so that you're able to better direct the patient's family on what to do next. And I always say you have to have that family discussion. You can't avoid it inpatient. You need to inform them of the prognosis. If they are in a persistent vegetative state, then you need to explain that to the family and tell them that, they still sleep, they still wake up, but they are completely disconnected from the world. They can't communicate with them. They are going to be incontinent of urine and bowel. They are going to need to feed through a feeding tube, and there is really no quality of life. And they have to decide if they want to proceed with a tracheostomy and PEG tube placement, and then subsequently transfer them to a long-term acute care facility, an LTAC, or whether they want to withdraw care, especially in older patients with major comorbidities like cancers. So that will be the discussion. In patients confirmed to be brain dead, if patient is an organ donor, protocols should be followed to contact the OPO, the Organ Procurement Organization, to get ready to prepare for organ harvesting. Otherwise, the discussion at that point is going to be on timing of the withdrawal of care. Maybe family members might want to say their last goodbyes or pay their last rites before you withdraw care. But when the patient is brain dead, there is no option on tracheostomy or PEG tube placement. It's pretty much withdrawal of care because, again, they are legally dead. So, again, you want to make this diagnosis so that you can advise the patient's family accordingly. So, again, I know this is not exhaustive. There are areas in cardiac arrest, prognosis that might not have been mentioned, but at least this is the the general overview on how to assess these patients, and that would help guide you as you discuss with family on the treatment plan, and the way going forward. So I hope this was helpful. Thanks.